Hi, everybody. Really fun to be here today. And hello to everybody online. I know a couple of my own beloved patients are actually online right now. So I just want to shout out and encourage you to ask questions. We will try to make sure we get to everything. We have a little bit of a fragile tech setup, so there's some manipulations happening up here at the podium. Um, I wanted to talk about something that I find particularly interesting, which is how do we employ great science to try to make things better for patients? And so I do have a little bit of an ambitious agenda, but we will get through this succinctly and then maybe talk a little bit about what we think about the future. So first, I'm just going to talk about the concept of radiation-induced fibrosis, or what I'm going to call RIF. Then I'm going to talk about acute radiation inflammation, some of the clinical factors that we know are associated with radiation-induced fibrosis, and some of the science that we are working on here at UCSF around the role of TGF-beta, superoxide dismutase, and some really, really cutting edge stuff, including gene therapy and stem cells. So radiation-induced fibrosis is essentially, if you think about it, your natural body processes trying to heal. And I have a bias that all human bodies want to heal. Your body always tries to heal, but that process is a little bit exaggerated, and perhaps you could even call it misguided in the context of healing from radiation. And I'm going to step you through this process because the basic science here is really, really important to understand so we can talk about what interventions may or may not work. So radiation actually ionizes with the water in your body. That's why we try to get you all to stay hydrated during your radiation. And we ask you not to take antioxidants during your radiation because we need those free radicals to form from the water in your body interacting with the radiation. And those free radicals, which you can see there form as H or OH, go on and injure the DNA in the cells of the tumor, okay, which is good. And those free radicals are called things like superoxide, peroxides, or free radicals. Okay, so keep that in mind. And then the process is that when those tissues, right, because we injure, as you know, the tumor DNA, but we also can injure normal tissues as well, all those different tissues issue these chemo attractants, or what we call chemokines. And these chemokines call to the neutrophils and monocytes, which are specific cells in your bloodstream that come into the area that was radiated and release different kinds of substances. And these are important words to remember: TGF beta or PDGF. Okay. Those two substances actually call to what are called the fibroblasts. The fibroblasts are kind of the cells in your body that sort of lay down the collagen basis of your tissues. Those fibroblasts come in, and the TGF beta and to some extent the PDGF stimulate those fibroblasts to actually turn into what are called myofibroblasts. Okay, I know this is getting complicated, but you're still with me, hopefully. Okay, okay, I'm getting some thumbs up. And so the myofibroblasts actually start to proliferate under the inflammation effect of the TGF beta. They lay down collagen, which is also called in fancy scientific terms, because as you all know, we have to have three names for everything. Every medicine has three names. Every science process has three names. Extracellular matrix, or ECM. And the TGF beta, in addition, reduces what's called the MMPs, or matrix metalloproteinase, which causes the ECM, the collagen, to be laid down even more. And then you get this sort of bland fibrosis, which is the picture you see here at the final end of that. Okay. So now you actually understand, you have an incredibly sophisticated understanding, probably better than 80% of the doctors out there, of exactly how radiation fibrosis happens. And, there's a lot of science here, but that is the essential story. All right, now let's first talk about the chemokines and the cytokines. We are looking at inflammatory science here at UCSF. Dr. Kober and I have a collaboration which involves several investigators in the radiation department trying to figure out why in the acute phase of radiation people get so tired. It's always surprising to me, even when we read a very small area, that people feel fatigue. And it's really interesting. We've just started to work on this, which is that some people feel morning fatigue, some people feel evening fatigue. And these are distinct pathways that are related to the specific chemistry of your body and how your body reacts in that inflammatory process. So we are just starting to separate that out. We have an NIH funded extension grant that is actually looking at patients who are receiving chemotherapy and radiation, where we're collecting blood samples and we're trying to figure out the gene expressions and the circulating cytokines to understand why chemotherapy and radiation cause this level of fatigue, because we think that that initial inflammatory response is important to understanding the whole cycle that occurs afterward. So what can we do about fatigue? Well, obviously, fatigue is a really complicated phenomenon, and you have to address any underlying medical problems. Like, some of the main ones I would mention are anemia, hypothyroidism, sleep disturbances, nutritional problems or fluid deficits, infections. These can all cause fatigue. Okay, so you have to address that at a sort of a baseline level. But then after that, what the clinical data shows is that there are actually very few interventions that work against fatigue. The positive ones have been exercise programs. Those are consistently the best and most effective at reducing fatigue. Smoking cessation, if there is smoking, and then actually preventing severe symptom clusters from getting into that loop where you have continuing fatigue and inflammatory response. Preventing that is important. But psychological interventions, integrative approaches, and drug approaches like Ritalin really have been sort of mixed in the literature, and I can't recommend those to you. So long story short, we need better interventions for this very common, which can be debilitating for some patients, and that's why the science to us is really important. All right, let's go back to fibrosis, the sort of long-term impact. We know that the dose of radiation, the volume of the radiation, and the size of the radiation amount that is given per day are all predictive for more fibrosis, right? That's why we give the long several weeks, because we're trying to reduce that long-term fibrosis effect. And we try to keep the doses and the volumes as moderate as possible when that is medically okay. The use of other treatments also adds to fibrosis, as you just heard from the really wonderful talk that Skye gave. So, chemotherapy, surgery. So we try to avoid the use of extra modalities if they are not needed. And I'll just say in the modern era, with intensity modulation and the really tight volumes that we draw now, this has really helped a lot. And then there are sort of personal individual factors, like whether you have things that predispose to tissue complications like lupus or rheumatoid or scleroderma. And then there are certain genetic variants that predispose to higher degree of fibrosis. So this is a complicated problem. Radiation fibrosis starts in at about 4 months. That's when the inflammation comes down and the fibrosis starts. That's why we get the PET scan at 4 months, 3 to 4 months, because that's right when we know that the inflammation is going out, and it won't cause a false positive on the PET, but the radiation fibrosis is setting in with a more chronic process. And many of you know that these side effects can be across different kinds of tissues, like the skin, the muscles, the joints, lymph fluid, like you just heard about, the linings, glands, and reduced capacity for wound healing. But what's really impeding us from making progress against fibrosis is that there is no grading system to actually grade and quantify and be able to scientifically study this. There are all these things out there, like measuring people with calipers or using an ultrasound or something. Nothing really standardized. So we are actually studying using AI analysis and MRI sequences that are very unique for fibrosis. One of our young faculty members in radiation oncology, Jessica Oli, is looking at that from a physics angle. And it is very much a physics problem, because the problem of collagen deposition, as all of you know from your own experience, your lived experience, is that when this is laid down, these areas become weak and susceptible to trauma. And the lack of blood flow actually causes contracture and tightening of the tissue, right? And you get this kind of what we call bland collagen background of fibroblastic change. And that is what fibrosis looks like. You remember going back that TGF beta is really, really important to the laying down of this background. And so we actually have a project now that I started which is based out of two things. Number one, my commitment to underserved populations. Keloid is a need that I feel very committed to for that reason, as it mostly affects the non-white populations. And secondly, this actually just growing out of my clinical practice, I suddenly realized this was an incredible opportunity to be able to understand the role of TGF-beta in misguided wound healing. So keloids, for those of you who don't know, is an exorbitant wound healing process that exceeds the volume of the scar, right? It's when it starts to spread outside the confines of the scar. And it's absolutely directly modulated by TGF-beta. So if we get to an understanding of this, we understand a lot about wound healing and fibrosis. And so we're actually doing a clinical trial of a TGF-beta inhibitor. We're just starting the work on this for patients who are going to be getting radiation therapy. And we have an award from FASTRO, our National Radiation Oncology Society, an innovation award to fund this. And we're going to be looking at immune pathways as well as RNA sequencing. TGF-beta, or its sort of mediator, CTGF, can be directly modulated to reduce fibrosis. So I just showed you an example with TBio-101 gel. It's really cool because it's a gel formulation, and there's other small molecule inhibitors that are out there being tested primarily in lung applications like idiopathic lung fibrosis. I was happy there were blueberries this morning because quercetin is actually a natural substance that's found in many kinds of berries as well as red onions. So I had plenty of those for my salad. And sulforaphane actually is found in broccoli. I didn't get to have any broccoli today, but I'll work on that later maybe. These all downregulate TGF-beta. That's true. So someone very knowledgeable over there who does know it's found in kale. Many different vegetable containers for these things. And then we can also regulate the downstream inflammatory and fibrotic pathways. So simvastatin and pravastatin, actually, believe it or not, they're anti-cholesterol medicines, but they also reduce collagen deposition and regulate CTGF. So in patients who can have these medicines for cholesterol reduction, I actually encourage them to take pravastatin. FACR was a really interesting phase 2 study that showed some effects there that were interesting. There are some drugs out there, imatinib and nintedanib, which are being tested for other kinds of cancer and lung applications again, and they both reduce PDGF, which you may remember was sort of one of those secondary signals. And then there are stem cell applications developing to reprogram fibrosis. We all know that steroids reduces fibrosis, but we don't like to use steroids, right? Because it's a blunt instrument. It's a big hammer for the problem that causes a lot of other side effects. So we don't recommend steroids. And then I was going to highlight, if you go back and remember, we talked about how part of that whole cycle of inflammation and response is related to free radicals in the tissue. And so if we could find a way to kind of cut down that free radical formation in a way that is safe and does not protect the tumor, that would be ideal. And so we're actually working on a study right now involving what's called metalloporphyrins. This is an example right here called BMX001. It mimics superoxide dismutase. So it actually removes the superoxides from the body. And it has some complicated physical properties where it actually inhibits HIF1 alpha. And that's an actual, like a pro-cancer transcription factor. So it has dual effect of anti-cancer and also scavenging radicals. And the nice thing about this is it's actually injectable because it's very stable for a long time in the human body. We have a national trial. Dr. Brazal and I from Duke and here were the two principal investigators on the phase 1, and we have a national trial open, which is a randomized trial trying to see if we can use this during chemoradiation injected twice a week to reduce short-term mucositis effects as well as long-term effects such as xerostomia and skin dermatitis inflammation. And our head and neck fellow this year, I'm very proud of, Dr. Mia Salins, actually presented an abstract on this phase 1/2, the earlier base study before we opened this national one, and showed that patient-reported outcomes actually rebounded by 1 month and returned to baseline by 6 months, which is pretty short. We usually see return to baseline by 12 months. So indicating some actual patient felt effects from that. And then, of course, for some of you in the audience who've been out from your radiation for a long time, your question might be, okay, well, there's the prevention side, but there's also the recovery side. And what can we do in the future for patients to try to help them cut that cascade off at the long-term time frame? And so one way, as some of you know about, is trying to actually restore oxygen to tissues, right? Because these tissues have lower blood supply. So pentoxifylline is something we give a lot, especially if you're going to have a surgical procedure or dental extraction. It makes the red blood cells more flexible, and those red blood cells can then get into that collagen deposit tissue and get in there better and provide more vascular supply to that tissue. Hyperbaric oxygen is a very, again, blunt instrument. It's a way to just force oxygen into all your tissues. And that's part of the reason why it probably doesn't work as well as it should, because it's very general as opposed to being specific. Bevacizumab, which is actually a chemotherapy sort of target therapy agent, actually inhibits VEGF, which is a molecular target that regulates how your blood vessels are arranged. So in certain specific cases of advanced radiation injury, we give bevacizumab to restore the normal architecture of the vasculature. And we only do that for very severe situations. As you heard about, there's lots of manual therapies because breaking up that bland collagen background can really help to sort of stimulate the ability of blood vessels to penetrate the tissue better. So we do recommend, but you don't want to traumatize because then you're causing more wound healing and more inflammation, right? So it has to be gentle, just like Skye was showing you in that wonderful demonstration. And then there's some ways like Botox or electrical stim that are sort of a little bit more experimental. I wanted to show people this because a lot of my patients are asking about this. So let's talk about the gene therapy and the stem cell approaches. There is a study right now that's looking at a gene therapy-based transfer of what's called aquaporin. So for patients who have long-term side effects to the salivary glands, this is a direct transfer back into the salivary glands to based on a gene therapy vector. And we are hopefully going to be able to open this at UCSF with some changes in the dental sciences departments. And then I also wanted to talk about this. This is something Dr. Ha and I have worked on for several years together with a scientific team. They were just awarded what's called a small business development grant from the NIH. And what they are doing is developing an injectable gel. As you can tell, I like injectables. Injectable gel where we're actually injecting cevimeline. And many of you may know about pilocarpine or cevimeline, which are used for dry mouth. But there is actual scientific evidence based on Dr. Bainey and Dr. Knox's research here, translational research, that if you inject cevimeline into these salivary glands, that it actually produces a sort of stem cell-like effect where those salivary glands can actually start to not only just be relieved, but regenerate. So we talked about, now you know a bunch of stuff. How does radiation fibrosis occur? Why do the acute effects of radiation result in fatigue, or at least what do we think? And that they are unique to people based on their, their morning or their evening fatigue and their individual makeup. We talked about some of the clinical predictors from radiation surgery and chemo that lead to fibrosis and what those long-term effects look like in the tissue. We talked about the role of TGF-beta, which is critical, and the science we're doing here at UCSF and keloids to try to understand that process better. We talked about scavengers, superoxide dismutase being an example of that, where we try to take the free radicals back out of your body. And we talked about gene therapy and stem cell regeneration. And the point I really wanted to make today, in light of the current environment and what UCSF is facing as an institution, is that continued research into fundamental sciences, the fundamental sciences that underlie these processes, is critical if we are going to make progress for patients. Almost all the research I talked about today in here is NIH or foundation funded. Thank you. Well, I hope not. Margaret Mead always said a few committed people could change the world. And, we've never made money from these studies. These studies are based on, love of patients, love of science. So I hope that people will continue. I think the big concern is that, If we don't have enough resources in place to support the next younger generation, that the science can't be sustained over, let's say, like the next decade. Well, like what's the long-term outlook in terms of those next generations of scientists and discoveries, right? Because we only have the discoveries we have now. But if we want to have more discoveries, we have to be able to bring those people up and train them. And none of them are making significant discoveries now. They're young, but they need support and they need resources, right? So that's I think that's something we're all a little bit worried about. But in terms of the gene therapy transfer, yeah, Jonathan, in answer to your question, it's very early on. I think they're just in the process, as I understand, of publishing their phase 1. And then this is their expansion phase 3. So it's still a long way off from FDA approval and all that kind of stuff. But I know Dr. Ha and I are we've talked about this and we're committed to supporting that if we can get an opportunity to participate in the trial. Yeah, I mean, it's very specific because when you get into that, I mean, I just showed you the list of pathways for fatigue, right? And even there, you've got like 10 that are breaking down into individual components. And so a lot of it depends on if the test is available and then kind of like who's paying for the test, right? So it's hard to do discovery if you don't have any funding to just actually even get those tests on a large scale. But I will say, with respect to TGF beta, the story is very instructive. So TGF beta has been known to be very intimately tied to radiation for a long time. And it's a beautiful target from the perspective of radiation therapy because it, A, is very much related to the control of cancer, and B, is very much related to the long-term side effects of radiation. So why we cannot target it is extremely frustrating. And the fact is that there have been many anti-TGF beta drugs and other approaches that have been tried, and they've failed due to just, I'm sorry to say it, like, the industry did not see a pathway to making money off those particular drugs. So, when you're talking about specific kinds of indications, a lot of it is about where can we get the sort of return on our investment. And at some point, if the approach is not looking like a return on investment, it won't make it. And that's where I personally think academia really comes in, because we will continue to fight for those approaches if we think it's going to be useful for our patients. So we remain very committed to TGF beta here at UCSF. We have an especially strong program. I very much believe in it. We are trying to work with some of, there is one company now that has a breakthrough agent. They're very small and fragile. And as you saw, we're working with this gel company, which again is very small and fragile, but I do believe in it and we are trying. In terms of profiling, that's not paid for in most situations unless it can really lead to something actionable that can be done for the patient. And so just, random profiling hasn't been shown to be useful for like 95% of patients. But if you have a specific type of cancer that's tied to a very specific, the way I just described, that very tight interaction with TGF beta, for example, and you have a lot of science that underlines the mechanistic relationship to that, then yeah, I absolutely think that's something that people should be working on and working for. But each cancer sort of has its own universe of those, right? So this is where you have to really be talking to experts about your cancer and what they think would actually be impactful for you, either now or in terms of the future, like what research is developing. Yeah. Yeah. So we're developing a proton therapy unit. It won't be available for a few more years because these are very, very large installations, and the amount of quality assurance and safety that's required to get a machine like that up and running to them, it's like, heavy particles, that kind of rip through your body. So we have to be really careful with that. It's going to take a while. And the center that we're planning is very big with a large research lab associated to it. We want it to be about scientific discovery. So that's all taking a lot of time. I'll just say that I think the really compelling need for protons is children, because, adults are just not as susceptible to developing later cancers from radiation. The risk is actually quite low. But in children whose tissues are still developing, radiation therapy, even just scattered, off-target doses, lead up to quite a bit of secondary cancers later in life. And so for children, I think the need is really compelling. And we have a big children's hospital here, so that's kind of goal one. But I do think for certain specific situations where the kind of lower dose, what I would call like the lower dose bath kind of around the target is a problem. And there are a lot of complicated things we could talk about, like when and when that isn't true. I think protons will be very useful. It's not a magic pill. Like it doesn't solve the fundamental problems. And actually there is some research that suggests that protons may even cause more inflammation. So, it's a mixed, it's, like all things, nothing is 100%, but it certainly does have some interesting applications. Yeah. Yeah. I mean, so many of these things come down to uh, where are we with that? Like in life, like there's things that are here and now that are really great and work really well. And then there's things in the future that might, right. Every day we're making those kind of decisions. So that's kind of like my just overall take is yes, those things are super promising. I'm obviously very interested in them from a technical aspect. They will have some really magnificent, perfect applications. They aren't here and now. They aren't as reliable. They aren't as proven as what we do. What we do here at UCSF, I'm very proud of. We've done for, essentially we were one of the first to develop IMRT because of our nasopharynx cancer population since the early 1990s. It works amazingly well. It gets better and better every single day. The technology, the software, the physics QA, the planning techniques are all improving every day. Our understanding of how to apply it. Proton and carbon are at a much earlier phase, right? So I know people sort of take offense with this in the radiation community, those who use protons and carbon, but I would say in my mind, they still remain somewhat experimental. And the exact uses where they're going to be the best and for whom remains a little bit unclear. I'm probably one of the more unbiased, neutral voices you'll hear on this. I do think we're going to be using them a lot, and I think they'll be really, really interesting for certain things. But every patient I see, I'm going to say, this is a choice between what's here and now and super dependable versus what might be better, but could be worse. I think the data are really complex. Yeah. I don't think we completely understand the data. I do think there's some good things that they will do, but I also think that, like I said, the technology is just still relatively rudimentary compared to the sophistication level of what's out there right now and how much control we have over it. Thank you.